listened today in morning regarding immunomodulation for breast cancer, the immune reactions, and in the afternoon session we listen how seroma formation can affect breast reconstruction, infection. And we know as surgeons, the way in which we act in a given situation is more or less influenced by the mental images or experiences that we have on the situation. Now, to understand a problem of breast cancer and its therapy, and to play an intelligent role in its management, needs careful study, needs careful observation, sometimes taking recourse to complicated statistical and analytical methods, which is sometimes not reachable to all the general surgeons. That into breast cancer, there are varieties of management, varieties of complications that we have listened. We have seen we can operate locally present breast cancer with lumpectomy or wide local excision, quadrantectomy, or we can go for mastectomy, modified radical mastectomy, again varieties, Achinclas type, Patty's type, and so many varieties of surgery, so varieties of radiotherapy, varieties of chemotherapy, when to give radiotherapy after a modified radical mastectomy, when to go for chemotherapy. All these things confuses me. Why there for a single problem of breast cancer, why there are so many roads to that problem, led me to think that why not single approach, that do a mastectomy and try immunotherapy at that time, local sites, try immunotherapy. Although it is not available in textbooks, in research publications, I try to experiment with bone marrow first, bone marrow therapy after modified radical mastectomy, in particularly locally advanced cancer, breast, which are more than 5 centimeter size, with involved axillary nodes, more than 4 nodes. I try to modulate the local environment by patient's own autologous bone marrow. And I will just now, within 5-10 minutes, tell you my experience. It is not well accepted worldwide, but this is my personal experience. I want collaborative study from any other institution. The global forum is here. Now, I work as a professor of surgery in a medical college, with a 1,000 bedded hospital. The volume of cancer surgery we do is very high volume. Now, this is our institute. Yesterday I showed you. Now, modified radical mastectomy, as we know, is the standard surgical procedure. Now, flap complications or immediate flap complications are delayed. Now, seroma formation, as you listened to Dr. Otar just now, and to our last speaker, the seroma complication is a nightmare for the surgeon who has put the tissue expander. It is a nightmare for the surgeon. It will lead to infection. It will lead to again problem. Morbidity will increase. And wound infection, stiff shoulder, also is a nightmare for the patient, for the surgeon. Now, late stage complications are local recurrence, nightmare for the patient, may not be for the surgeon, but hypertrophic scar, keloid formation in the late stages are also very important for the patient. Now, autologous bone marrow therapy applied to flaps during mastectomy in this study is found to prevent some of these complications. I'll just now show you. Now, this patient had this tumor and prepared the site on the table. This is the bone marrow needle that I take, and I prime with heparin because bone marrow will clot. Under anesthesia, I take before surgery from the sternum, the bone marrow, then prime that bone marrow with the heparin so that it doesn't clot till I finish the operation. Then I raise flaps. This is the upper flap and the lower flap. Both flaps raised. Now this, you see this pectoralis major. This is that window to axilla. This is the breast. Window to axilla, where we enter the axilla or axillary dissection. The foramen of Langer, it is called. Now, this is the total modified radical mastectomy in toto removal of the breast containing the tumor, a disc of skin, nephil areola complex, axillary tail here, and the axillary group of lymph nodes. Now, when you remove all this voluminous tissue from the local site, it is going to cry. The local site is going to cry, and cry what? It may cry blood immediately, or it may cry seroma formation. So that is, the seroma formation prevents the surgeon to immediately put reconstruction surgery. So, what I do, the bone marrow that I have taken, in the subcutaneous tissue under the flap, 0.cc, 0.cc, 0.cc I inject. And inject to the pectoral muscle and to the axillary walls and the lower flap also. Then after that I put the drain. The drain must be put, because it will not drain the bone marrow that you have infiltrated into the subcutaneous tissue. It will drain any crying fluid that is coming from the wound, either from the bed, from the axilla, or from the flap. Now this after the completion, the drain is there. Now this is a control group. This is the control, and this is the study patient. This is the control patient. Now what I found, there is no marginal necrosis in the study one, while there is little, you can see little marginal necrosis here. And post-operatively, the seroma collection drain output significantly less in the study group, while it continued for 2 weeks in the control groups. So my objective was to find the effect of this autologous bone marrow infiltration to breast flaps for preventing early breast flap complications, which is the nightmare. Now what methods I used? I first took institutional ethics committee clearance, because this is not accepted method. Cell therapy is not described, not recommended. So I took institutional ethics committee clearance for that, and informed consent of the patient. Now I took 40 patients with T1 to T3 and 0 to N1. So the patients, 20 patients were kept in study and group and 20 in control group. In the study group that I showed you, on-table bone marrow was aspirated from the sternum of the patient. I did not aspirate from the iliac crest, because I prepared the pectoral area with antiseptic just prior to the mastectomy. Now, priming the bone marrow with heparin to prevent clotting, because I first aspirate, because after raising the flap, it is not wise to go into this bone marrow. Now, skin flaps are closed with drain, bone marrow infiltrated that I showed you, and pressure garments I apply after the surgery, and suction drains are routinely used. In 20 patients of the control group, flap complications were noted, flap in 6 patients in control group, and seroma collection in 9 patients. 1 patient required skin grafting, while flap necrosis was less than 3 centimeter, in 5 patients of the control group, they allow to heal with secondary intention, whereas larger defects in 1 patient of the control group was treated with skin grafting. No major flap necrosis was observed in the study group. Only marginal necrosis was observed in 2 patients out of 20, which healed within 1 week post-oply without any intervention. Now, I made a post-operative pain marking. I asked my resident to ask the patient to teach them before the operation and give a mark: mild pain, moderate pain, or severe pain. And seroma collection are observed in the drain fluid. And flap necrosis. And the post-operative day 1 in the study group, mild pain, while in the control group the pain was severe. While when day 3, still mild pain was persisting, and here in post-operative pain decreased from severe to mild. In 5th day, post-op pain, there is no post-operative pain in the study group, but in control group, mild pain was persisting. On 7th to 10th day, pain has disappeared, but here in the control group, mild pain persisting and shoulder stiffness were persisting. And gradually you see the collection, the decreasing, but this is persisting. Flap necrosis was present, and 3rd day it was marked in the control group, while there was no flap necrosis in the study group. Now, there was one, on a 2-year study, there was one local recurrence in the control group. You can see local recurrence. Why there is local recurrence? If you done MRM, well, if the tumor size is more than 5 centimeter, high-grade tumor, if there are more than 4 lymph nodes in the axilla with extracapsular extension, as Dr. Ota told, or if the marginal line of resection, when the surgeon is operating, the line of resection he is not observing under microscope. So line of resection may be positive. That's why it has recurred locally in control group, but no local recurrence observed in the study group. So I conclude, this is my personal observation, to minimize skin flap complications, and particularly seroma, to surgeons and oncoplastic surgeons, plastic surgeons who are using tissue expanders, as told by Dr. Ota and others, they can use the autologous bone marrow of the patient and simultaneously put the tissue expander so that seroma collection, wound infection, local pain may be less. And I will have to have a collaborative study for that. So lesser use of cautery, infiltration of bone marrow, routine use of suction drains, and application of pressure garments are required. These are the references I used, and this is my procedure. Now, describing these procedures in these conferences appears very easy, very simple. But behind every simple thing, easy things, lies much debates, much dialogue, much thinking, much struggle against odd, against many odd. And I thank you for your patient hearing. And thank you, sir.
Okay, next speaker is Dr.